Hi, everyone. Thanks for being here. It's our pleasure today to welcome back a friend and affiliate faculty of the center, Dr. Amit Chandra. He'll be continuing the theme of our speaker series on personal stories and reflections on global emergency care. Dr. Chandra currently serves as Senior Emerging Health Challenges Advisor for the USAID Bureau for Asia. Prior to this position, he worked as a consultant for the World Bank on health financing and disruptive technologies in health, an advisor and project lead at Millennium Challenge Corporation, head of an emergency department at the University of Botswana School of Medicine, and numerous other roles. All, get this, while maintaining an active career in clinical emergency medicine. So to the residents, fellows and junior faculty on the call, Dr. Chandra is one of the few who can provide an example of a highly successful split career that has been forged outside of academics. And if you encounter him on the tennis courts, beware that he has a need for it. So without further ado, Dr. Chandra, the floor is yours.
Great, thanks, Nico. As Nico mentioned, we'll keep this informal and we'll try to only take up 20 minutes or so of speaking. And then I wanted to run this as kind of a ask me anything session. So if you have questions about, getting field experience, non-traditional career paths, academic versus community clinical work, USAID, what is it? What do they do? Some of my, one interesting part of my US government experience is working through transitions. Started my one position under the Obama administration, transitioned to the Trump administration, and then more recently transitioning with the Biden administration. So that's interesting things I'll leave for the Q&A. But for my own notes, it is kind of tough for me to follow Heike last month. She's a close friend of mine from my time in Botswana. We were very closely supported in our project by the South African emergency medicine community, and particularly those involved with the Emergency Medicine Society of South Africa. But I will do my best to do justice to that prior lecture from last month. And share a bit about the trajectory of my career and maybe some of the struggles and lessons that I've learned. And I think often when people share their career story, they make it sound very well planned and that, everything, they had a vision for what they're doing, even 10 years earlier, but I will attempt to not do that and to share some of the difficulties I had and some of the kind of lucky breaks that I got, or the fortuitous nature of all of this, that it's really hard to have a clear goal in mind. And maybe that's one of the lessons learned is staying flexible and building that flexibility into your career planning. And I'll also start with one quote that I like, and the quote is this: that experience is something you don't get until just after you need it. And I think that quote kind of frames a lot of my career trajectory and how I experienced a lot of the various milestones in my global health work. So a bit about myself, I think global health was my reason for going into medical school. I had actually done an undergraduate degree in economics and a master's in development economics. And it was really this interest in the structures behind poverty and underdevelopment, particularly around public health systems, and the gross inequity around global health challenges, illnesses that easily prevented or treated here at home, but so often fatal elsewhere. And so these are the kinds of things I was thinking about and was passionate about going into medical school, with an idea that somehow I would bridge this gap between what I was interested in and what I had studied, and clinical science and the clinical skills that I planned to get through medical school and residency. So fast forward 4 years, it's time to choose a specialty. I chose emergency medicine. I hadn't gone into medical school with that plan, but really just the specialty, the people, the social safety net aspect of it really resonated with me. And at the time, I thought it was a perfect match for a global health career. I think I'm happy I made that decision and happy that I count myself as an emergency physician. But I think that choice also did dictate some of the future opportunities that I had. I think emergency medicine was not as present on the global stage in the way that I wanted to do my work. They're definitely there when it comes to disaster response. I think at my time, they started to expand into education opportunities and expansion of the specialty. But I think I did and have struggled with being an emergency physician, but wanting to work primarily on health system strengthening. I think COVID-19 pandemic response is one of the first times where I really see a major role and more wider achievements by the emergency medicine fraternity in that space. So it's exciting to see that transition. And so now let's fast forward again. So I finished my residency and I just felt like I had all this pent up energy in terms of global health. I had gone into medical school with this idea of what I would do, but medical school and residency, my global health experiences were quite limited. A research project here, 1 or 2 month rotation there. And so I, spent my first year out of residency working at the same hospital and looking for the right opportunity to really move overseas and get some sort of foundational experience, which I found by actually getting a job with the government of Botswana with their Ministry of Education. Hired me to be faculty, junior faculty at one of their new startup medical school. So I joined 2 senior emergency physicians as part of the team, and we worked in the National Referral Hospital. We were doing lectures at the medical school. We launched a medical student rotation as the first students were coming online to get to the year where they were doing their hospital rotations. We launched a residency program. I mentioned I was connected to Heike and Lee Wallace. So in my role in Botswana, I helped in the early years of the African Federation of Emergency Medicine as a board member. And a lot of other collaborations with some maybe familiar names, Ben Wachira, Lee Wallace, Heike Gedold, Terry Reynolds in Tanzania, and many others who were involved in different medical education programs throughout Southern Africa. Just kind of reflecting on that experience, I did feel, looking back, and even coming out of the 2 years there, that my direct patient care experiences, it was exciting and I was thankful to have that opportunity in the moment. But I did find it a bit less impactful and less fulfilling in that way than my public health and health policy work there. And I think that's because, coming with a US level of emergency medicine training and trying to adapt that expertise to the clinical context in which I was working, I was really hampered by all of the health system challenges that I started to frame under the various health systems framework that I was kind of feeling and butting my head against every day. Things like governance and human resources for health. I did work during a 4-day health worker strike, national health worker strike, that really reframed my own thinking on what I was doing. I had to kind of question to myself that, why am I, as an expatriate, the only person showing up to work when, the partners, the people I was meant to train, have left their posts over that period. Supply chain was a major issue. Botswana is an upper middle income country, yet we were dealing with stockouts every day. I was hoarding diazepam vials in my hospital desk for several months because there was no sign of any benzodiazepine for months. So I would go from ward to ward to collect a few vials just to use in case someone came in stat epi, since that was really our only option to treat it with. Running out of gloves, running out of normal saline. So very concerning things to be running out of when you consider the high HIV rate that we were dealing with in Botswana. And on human resources, a large percentage of the doctors, both at the medical school, but also the line physicians, the so-called medical officers, were non-citizens. This is kind of one of the challenges we hoped to address with this medical school. Instead of sending students abroad to study, and they may or may not come back, training them in the country and keeping them in the country and hopefully having them have a long career there was the idea. But at the time there was this kind of uncertainty and this uncomfortable nature of being largely expatriate African staff, people from Nigeria, from Congo, from Zimbabwe, led to a lot of kind of cultural barriers to care and a lot of challenges that we were really seeing on a daily basis. And then a lot of ethical care challenges. What do you do with a coding pediatric case when the ICU at your facility has 100% fatality rate for pediatric patients? No exaggeration. So it really makes you ask these questions. Should we be resuscitating these and other similar cases? And I reflect back on Dr. Heike's point she made last month around the challenge of urgency and thoughts on out-of-hospital cardiac arrest. Are the models that we are trained on and that we hold up as the gold standard, are they an appropriate standard for other country contexts? These are kind of questions that I found myself asking over these 2 years. And then kind of the personal, I would say, trauma, moral injury of just the countless patients over those years lost to these systems failures. And I felt like I was able to make some systems-wide impact on my own department. I could streamline our own medicine cabinet and pharmaceutical ordering system, but still our forms end up going into the ether whenever there's a stock out. No matter how well organized our cabinet is, there's still an empty shelf every day that you have to come in and respond to. So I'm looking at my notes, so I'm just scrolling down a bit. And then I think just a lot of misadventures over those 2 years, dealing with a lot of international partners, people that were in the similar position that I had been in previous years of my life, coming from international institutions, either coming for a short-term rotation or having some grand idea about a new tool that they wanted to implement. And I'll maybe share one anecdote of a delegation from a leading European medical center. I won't mention their name because this isn't a favorable story, arriving with an app to treat a particular medical condition, literally shopping around a solution, looking for a problem, looking for a country where they could implement their solution, designed in their home country, to generate the research, the data, so that they could, do God knows what with it after that, but at least get a publication. So I think all of these experiences that I've shared, and happy to share more in the Q&A, really led me to change the lens that I was bringing. And that I think that's why it was a foundational experience for me, is that now that is a different lens that I bring to all of my future global health experiences. And I think it's served me well to have spent those 2 years and to have gone through those struggles, first as a junior faculty, and then given the human resources challenges I mentioned, I very quickly found myself head of department. This is 1.5 years out of residency, which came with its own challenges, being someone relatively young, sitting at the table with very senior people representing other specialties. So I think a lot of hard lessons learned there. So, returned to the US with all of this experience, very frankly, feeling pretty burned out from it. But I did feel like it honed what I thought I wanted to do in global health. I had struggled through that experience, but honed in on this topic of health system strengthening as something that I wanted to direct my energy into. And I thought, maybe arrogantly, that I had a master's degree in economics. I had 2 years of field experience. I was a board certified, emergency medicine specialist. I'm sure within 6 months to a year, I'll have a great position working in this field. And came back and just really struggled without having the network, without having the specific experiences that it takes to work on those topics. Came back to the DC area, was applying to a variety of clinical academic positions focused on global health. But I think I had really honed in on more program management, technical specialist roles, either at a USAID implementing partner or at USAID, other development agencies, the World Bank, et cetera. And thankfully, I managed to find a clinical role that really kind of spoke to my my soul and my interests. I ended up working as a PRN physician with the Indian Health Service, flying to a Native American reservation in South Dakota every month. And I would do a string of 7 to 10 shifts at a time. And then I would have the rest of the month off to network, go to meetings, work on other projects, work on consulting opportunities. And this was meant to be a stopgap measure, but I think I ended up doing it for about 3 years, over 2.5 years, I think, until I found my footing here in DC with other career opportunities. And those opportunities came in the form of consultancies at the World Bank. Was brought in for a 5-day project and then managed to make a network to then be on their consultant roster to work on a variety of projects. None of which really had anything to do with emergency medicine very specifically, but more required me to rebrand myself more as a clinical health specialist, someone with broad clinical experience that could be applied to a variety of topics. And then also there, I found that I was really dipping into my economics background, working with economists on a variety of research projects and bringing that lens of thinking back into my work, which was really exciting. And around that time, I also learned about a fellowship program that seemed to be well suited for me and well suited for the challenge I had identified. And that is a fellowship program run by the American Association of the Advancement of Science, AAAS, and it's called the Science and Technology Policy Fellowship. So very few clinicians do this program. I think it was designed for people with a PhD in any science, but you're also eligible to apply with medical or veterinary degrees. And the AAAS, in running this program, provides their fellows with a pretty intense and excellent professional development program to kind of introduce you to policy topics, communication skills, public speaking, a variety of interesting topics. But as your day job in the fellowship, you're placed in a functional role in a US government agency. So this kind of addressed my need to get the experience doing this kind of work that I had identified, and not being able to break in because I didn't have the experience. It was the classic chicken and egg problem, which is solved by these programs. There's a few similar programs, but this is the one that I did, and it enabled me to get 2 years of experience working at the Millennium Challenge Corporation, which is a U.S. government development agency separate from USAID. And when I arrived there, they had never had fellows from this program before. So myself and the other 3 fellows that arrived, I think, we didn't really know what to do and what they wanted us to do for the first few months, but was able to take advantage of some opportunities that came up and some gaps in their staffing that needed to be filled with someone with my expertise, and ended up within 4 to 5 months being named a project lead for an ongoing nutrition project based in Indonesia, which I then worked on that project for the rest of my time at the agency. Again, not very emergency medicine specific, but really drawing on all of my knowledge and skills acquired through medical school and acquired through my overseas experience and some of the systems thinking and economics approaches that I had been building over those interim years. Generally, people who get these experiences with the fellowships have the option, have a lot of opportunities to continue in a similar role. And for me, the timing was a bit off that my fellowship ended on the academic year in August, and that was the year that was the administration to the Trump administration, the transition to the Trump administration. And along with that, a lot of uncertainty around global health budgets and the hiring freeze. So I did find myself back on the market. And that's, when I first started that job, I had also taken up a PRN staff position at Inova Alexandria Hospital. So I was able to dial up the clinical shifts, go back into the consulting pool, rejoin my World Bank team to work on a variety of projects. And I remember doing various similar career talks as this one with other programs that I support. And during this time, I really kind of felt like I was depressing the people that were in the audience, because I felt like I was, almost there. It was a lot of fits and starts, but I hadn't landed the right thing. And really sharing more of my struggles than my successes in those interim years. But I think happy to report that, applied for a job at USAID, and now I work at the USAID Bureau for Asia. I joined as as one of around a 6-person help team. So we sit separate from the Bureau of Global Health. I sit in a regional bureau. And so I joined the team in September of 2019. My topics that I was hired, and my topics of interest, were air pollution, climate change and health, and digital health, which are other skills or topics of interest I had developed over previous years. And then I specifically was meant to track the health portfolios of our our India team and our Vietnam teams. So I had about 6 months in the office, 1 field visit, and we coordinated a training. So I was able to meet people from many other countries in Asia that were part of our field missions, and was kind of perfectly timed for the COVID pandemic. In fact, we were hearing about the first cases while we were out there. And while I was in India, they were working with our field mission there. They were evacuating the Indian medical students that were studying in Wuhan. And I don't think I could have predicted where we are today or the experience of the subsequent months, but managed to come back to the office for another few weeks before we went into lockdown. And kind of, I had alluded to this earlier, I hadn't felt that emergency medicine clinical skills would play a big role in my position. But then with the COVID pandemic, working on global donations of ventilators and figuring out how to do that safely, working on all sorts of other emergency response capacities, triage, medications, other health commodities. Really, it expanded my scope of work quite a bit, and really tapped a lot of these skills that I had developed, treating patients on weekends and holidays intermittently, during that year. And then also taking what I had learned and, really just trying to shut down the bad ideas and to catch missing pieces of the puzzle, things that I could see would be needed for a program to be successful in making an impact as a pandemic response capacity. So I think that brings me to the present day. I'm still at USAID, still working on some of these non-COVID projects, working on things like smart cities, urban health, air pollution, climate change. But still a lot of our day-to-day work is related to COVID-19, building oxygen systems, vaccine delivery systems, other things that can prevent and maybe mitigate some of the harm of the virus. And maybe if I'll leave with maybe a few general career lessons that I would pass on. It's that I think there's many ways to go and many paths to choose. And they're all valid as long as you have kind of a general purpose or direction that you want to go. And you kind of have to plan to adapt, and don't stay the course if it's not working for you. As opportunities come up, and if you feel like it's in line with your general interests, it's probably a good idea to take advantage of the opportunity, because it's hard to know where these opportunities will lead. I had joined Millennium Challenge Corporation without any portfolio of work, and that allowed me to get this really in-depth experience in Indonesia. And that experience in Indonesia was one of my qualifications to get my current job at the USAID Bureau for Asia, since Indonesia is also an important country for our team. I was consulting at the World Bank when I was after MCC, not sure where I would go next. I ended up working on some topics related to digital health. And then that digital health expertise was the other factor that helped me get my current position, because they really wanted someone to track that in depth. And in fact, just this year, I started teaching a class at Georgetown to their Master's in Public Health program on digital health. So it's been a real exciting opportunity for me to expand my knowledge into something I'm interested in. And then my second piece of advice would be to build in flexibility in your time wherever you can, because again, and without that flexibility, it's really hard to take advantage of opportunities as they come up. And then finally, I think maybe my story reflects this as well, as just the importance of mentors and providing mentorship. This requires networking, and really it's about the point that you don't know what you don't know. By the time you get the experience, it'll be too late to apply to the problem that you were just dealing with. For example, I didn't know about the AAAS fellowship until a third order meeting, meaning I met someone who introduced me to someone else who introduced me to a third person. My first World Bank consultancy was also landed through a third order meeting. The first of those meetings I wasn't really interested in taking, but I thought I'll go meet this person and see if I can interact with that. And so it's painful to do this, but sometimes you make new friends and new opportunities crop up. And I think that's part of the fun of working in global health, is working with other interesting, passionate people who are doing amazing things and are quite inspiring. So again, that brings me back to my thoughts and how excited I was last month to be in the audience during Heike's talk. And so I think I'll end there. So I think I took up half the time, so maybe a little more than I expected, but maybe over to questions from the audience.
Thank you so much, Amit. So we've got a small group here. We can really open it up for discussion. People can raise their hands if they want, but honestly, you can also just feel free to speak up. And if I can, I'll take the privilege of going for the first one. Okay, Amit?
Sure.
So I knew you had occupied many roles, in your path, but I don't think I understood quite how many until today. And in hindsight, I think it really does sound linear, although I'm sure it did not feel that way at all at the time. Anyhow, I wonder if this new position at USAID, this emerging health challenges advisor, will become a real home for you that you kind of live with for a while. Do you think so? And can you tell me a little bit about what you hope to do with the position after COVID? What is the position, and where do you think you'll take it?
Yeah, and in a way, I kind of have a special projects role within the USAID Asia Bureau, and being in the regional bureau and not being in the Global Health Bureau, I find the Global Health Bureau, there's a lot of really experienced technical experts within the silos and the structures of that bureau. So there's the Office of Maternal Child Health, there's the Office of HIV/AIDS, and you'll have world-renowned subject matter experts within each of those pillars. But I think in the regional bureau, we're meant to, first of all, look for opportunities that aren't being met by the pillar bureaus, pillar being the one focused on that topic. Also looking for opportunities across the region and tracking the portfolio of work in our specific countries. And so maybe just a bit about USAID. Projects work kind of in two ways. A project can be managed through headquarters in DC. And in that way, if it's a health project, it would be managed by the Bureau of Global Health for the most part. And that might get seeded with some funding from HQ, but also get seeded from funding from the various country missions that want to engage on that topic. It's called a buy-in. So the India mission can buy into that project. So that's option number one. Option number two is that our team of staff in the country at USAID at the field office, which is often co-located at the embassy, they can launch their own project specific for that country. So it's called a bilateral program. So the India mission can launch Program X, and other people in other countries might not really know about that program. And the people in the Global Health Bureau might not know all the details of that, but we in the regional bureau need to be tracking that. And so I think to answer your question, I only kind of learned about this after I accepted a job with this unit, but it's one of the reasons why I really enjoy my position in this bureau. Not only do I have a great team and a great supervisor, but I think that flexibility, not being siloed under a particular topic or office, gives me a lot of kind of creative energy and scope. So I think the projects that I'm working on for the future, working on one project that's looking at, kind of beyond our, I mean, within health, there's so many silos, but health itself is a silo. And often the biggest impact on health might come from other sectors, from education, from democracy and governance, from economic growth. So I'm now working on a project looking at smart cities. So from an urban spaces lens, which is very unique to Asia, since that's, most of Asia is urbanized and most of the mega cities of the world are in Asia. And I'm actually working with people from other sectors to make a cross-sectoral program. So this won't be a health project, this will be an urban project, but will be designed by health people, by education people, by democracy and rights, human rights specialists, and all working together in an urban space to achieve a variety of goals, to be determined. So this is kind of early days yet, but it's also an opportunity for me to lead a project design. So that's exciting for me. And I do feel like, the variety of things that I can get involved with, because I can also volunteer when the Global Health Bureau needs someone with my expertise. I was helping develop a formulary for medications and supplies to be used for COVID response, based on my very specific expertise. I thought that would be a good way for me to contribute. So I'm able to do things with them, but also able to do a bit of out of the box thinking where I am now.
Hi, Emmett. My name is Amina. I'm pediatric emergency medicine. So it's really interesting because it seemed like you had a very flexible kind of mentality to be able to kind of transition between all these things. But there must have been something that brought your application to the kind of top of the pile, some skill set, something that you kind of, brought with you to every kind of opportunity that you had. So what was it that, kind of helped you stand out when you were looking for, or just, applying to these different positions?
That's a great question. I think part of it was luck that the particular topics that I had on my portfolio or my interest happened to align with the needs of those different positions. But I think actually maybe a very specific answer to your question was technical writing skills, which I've worked on a lot over the last decade. And I'm not talking about academic journal writing, I'm talking about something else here. And so this is writing about technical topics, either for example, blog posts and reports, or either for specialist audiences or for an educated lay audience. So I've written a few articles for Salon.com, for the Council on Foreign Relations, Think Global Health. I've contributed to a lot of the drafting of different World Bank reports related to some of the projects I worked on. And so it's a skill that I also was able to strengthen a lot in each of these roles, but it was also a reason that they hired me was because I would work on that. And so I'm not sure. So I think that was an answer, is because I could plug in with that and taking that role on the team. to produce the written products, because in a way, everything is a written product, every email, every summary. But then especially when it's external facing, sometimes you'll be working with professional writers, but they need the technical person attached to them at the hip who can also do some writing and understand that nuance. So I think that I would say actually that's one of my key skills that I bring. And then maybe secondly is a willingness and maybe an aptitude to jump on new topics and maybe not be afraid of a new topic, to immerse myself in it for a few weeks and then be able to digest it into a technical writing product. So one of my projects at the World Bank, I told you I started with a very small project where I was basically translating and grouping ICD-10 codes. So something really any practicing clinician could do. But I think they offered me another project, which would be to design an evaluation tool to see how countries are doing in their national vaccination programs, routine vaccination programs. So as an emergency physician, not really a topic I had an in-depth background in, but the reason they offered it to me was because I happened to be sitting there in the room. They pivoted to that topic after meeting with me and closing down that project meeting. And they had hired a consultant who had spent 3 to 4 months and ended up taking another job and didn't give them any product. So they were very far behind. They needed someone who would dive in. And I was literally in the room. I'm already a consultant. So they said, can you give this a try and give us an outline in a week or two? And so I was willing to do that. And I ended up basically being one of the co-authors of this vaccine evaluation module in a larger health systems evaluation tool, which has now been implemented in many countries around the world. And I got to travel to Indonesia in order to do a pilot of that tool. And if you remember the timeline, I went to Indonesia, was able to network there. And then when I got my job at MCC, then I was able to jump into that Indonesia nutrition project. So again, it's very good luck that the agency that I joined also had a project in Indonesia. And while I was working on that project, I ended up interacting with a lot of the people that I had met on that World Bank trip. So definitely a small world, and it's hard to predict how opportunities lead to other opportunities. I haven't done much work in the vaccination space since then until COVID, and now we're doing a lot of work in vaccination again.
Amit, how do you maintain your connectivity with the work? So, when you're in Botswana, you're like frontline, seeing patients, very much connected to the work. I think a lot of people in this group are now struggling with the fact that we have all these countries that we're trying to support, but we're so remote. And so how do you stay connected to the teams and the people you're trying to serve when you're based here in, DMV?
Yeah, that's a good question. I think prior to COVID, it would be, going on site visits, field visits, also just spending time with your team members in the other countries. That's not scheduled time, right? So when I went and I spent 3 weeks with the India mission in that few months before COVID, we did a field visit, and I was in a 8-hour car ride with 3 colleagues. And so, that's a lot of time to spend in a car ride with people who you barely knew before. And we came out of that experience, friends, and we were talking about, some work topics, some non-work topics, and really thinking critically and creatively about some of the challenges that we were working on. And in a way, that car ride was almost more impactful than the 1 to 2 hour site visit at the location that we were aiming to go to. And so I think now during COVID, in a way that's of course become much more difficult to do because of the, we can't travel and spend the time in the same room with them. But in a way, it's democratized how you can connect with people, because everything is now online. Everyone is online. And so, I think to specifically answer your question, it's how do you replicate that unscheduled time? And, so spending time with people, now you can do it wherever they are in the world, but not without a specific agenda, or with a very loose agenda. So you can also, have that space where you're not trying to get through 10 action items and then your hour is done. And I wonder if post-COVID, that opportunity may not be there, because like I said, right now, everyone is online at all times, but I don't think people will want to be on Zoom or Google Meet as often as they have been once things open up a bit. So remains to be seen. Yeah. But maybe I don't know if this is what you're asking, but it makes me think of, that's one thought and a challenge for people who go into global health, and especially people with clinical backgrounds, is that the work I do right now, even in the best of cases of being connected to the team and so on, it's not me physically treating an individual patient, which is something we all have the qualification to do. But I think working in a career in global health, unless you are working in a clinical service capacity, you're not doing that. You're doing meetings, you're writing reports, you're planning projects, implementing projects, emails, 10 more meetings. Let's add the word meeting to that list 10 more times. And so that's something to think about if you can, if that suits your personality and it's something you wanted to do. And I think for me, when I had that opportunity at Millennium Challenge Corporation, working in an office, having a desk, when the phone rings, you answer it. Unlike at the emergency room, right? At the emergency room, I never answer the phone. It's never for you, and it will always cause you a problem if you tried to answer it. But when you sit at your desk, it's someone calling you with a question. It's kind of a different experience, and one that I enjoyed. And I think that's what was my proof of concept that this is the kind of work I wanted to do. And I think that's why I've also been dialing back my clinical more and more as my non-clinical career is expanding. I think I'm okay with that. I do have second thoughts about that, and in terms of keeping up with skills. Just before starting my USAID position, the timing worked out well that I was able to do my APEM research, so that was good. So I'm good now for the next 10 years or whatever the new system is. But yeah, that's also a question I struggle with.
The new system's super easy. You'll be fine.
Amit, I feel like part of your success in global health, and I might be generalizing, but I think people who have been really successful in global health careers who come from a clinical specialty, part of what they have to do is jettison their loyalty to that specialty, because that's not what global health is. It's not advocacy for a certain specialty. But I still really ponder this quite a bit about emergency care and the global health agenda. And I feel like we will know that emergency care has made it when it is being actively promoted and discussed in the halls of a place like USAID. Do you see a scenario where something like that ever happens? And if it could happen, how would this fanciful scenario unfold? Sorry, that might be really tough and unanswerable as well.
I kind of like how you phrased it about jettisoning the loyalty. And I think you really need to take an expansive view of yourself as well, that you are an emergency physician, but you're also something broader. You're a physician, you're a specialist, you are a health scientist, right? And these are the reframing that allows you to take a more expansive role when you're seeking out opportunities. But that said, when you are coming to a specific problem or project, I think we have a huge advantage with emergency medicine clinical training, that we know quite a bit about a lot of different specialties, and we can draw those cross linkages that perhaps an internist or a pediatrician or a OBGYN or a surgeon, they would of course know more than us about that pillar, but they wouldn't necessarily know those cross linkages or those health systems aspects that we deal with every day working in a clinical setting, wherever you are in the world. It's largely yes, there's clinical knowledge, but the operations of it, you're butting up against the contours of your health system in a way that other specialties, I think, don't. And as for your question about, future of emergency medicine and global health, if you had asked me before COVID, I thought the chances were low, except around some particular topics like road trauma systems, things that we could ally ourselves with other specialties, maternal mortality, emergency care of patients to prevent maternal mortality in different settings, kind of piggybacking other existing topics or topics that are rising on the agenda. But I think now, the COVID pandemic has proven the need for acute care, for triage, for qualified people on the front lines to manage, what are the life-saving treatments that can be administered now? Who are the people who can safely go home as well, which is equally important when your health system is overwhelmed. How to manage and marshal and manage resource use efficiently, effectively, equitably. These are all the kind of questions that are emergency medicine topics, and maybe when we hear about them, they might not be labeled as emergency medicine topics, but I think we're very well placed to work on them. Yeah, hopefully that answers your question.
We're starting to approach the end of the hour. I think there's another minute or two, if somebody else has a burning question. So I'll pause a bit, but if not, we can always close.
I might add another thought on the loyalty to the specialty. And I think that's one reason I've enjoyed working with you, Nico, and Bhakti and Junaid when he was at your program, that you really kind of took a more expansive look at what emergency medicine means in the global health space, doing things like economic impact analysis and cost effectiveness analysis, kind of thinking outside of the more traditional box of let's start a residency program in every other country, which definitely has its value as a piece of the puzzle. But I think in many settings that may not be appropriate, or that might not be the best way to promote emergency medicine at this time. And so thinking more broadly about what else can be done from our specialty, how else can we contribute in a more wider variety of locations. Sorry, I think someone was speaking just as I began to speak, so.
Hi, Amit. Hi, everybody. This is Amber. I used to be a part of this group. Now I've moved to University of South Florida. I enjoyed your talk, although I joined a little bit late, and kind of I can relate to a lot of things that you said. And I just wanted to jump in because of this, loyalty to specialty business. And if I don't know if many people know that, but I was trained as surgeon, then I moved to emergency medicine in Pakistan. We were the few grandmother of the specialty back then. And then I transitioned completely into public health research, mostly focusing on trauma care and injury surveillance. And now here in University of South Florida, I'm leading the Global Disaster Management, Humanitarian Assistance, and Homeland Security concentration. So that just that sort of drives the point home that you, like people evolve, your aspirations, your interests, and your passions also evolve over time. And it's never a bad idea to explore and do different things. And especially in this time where, the old school sort of, doctrine of sticking to the, one specialty, becoming the armchair professor and retiring from the same institution where you joined as a student is kind of dead. to be honest. And the transdisciplinary and interdisciplinary nature of both public health practice and research is kind of the thing to grasp right now. And the whole notion that, if I'm an emergency physician or I'm a surgeon, I'm only qualified to talk about surgery or emergency medicine, that doesn't work anymore. I'm leading Homeland Security. I have never worked domestically. I was a global, health researcher, but you apply a lot of different things in the context that you're working in. And I think somebody who has worked in clinical specialty in public health and research and practice, I think one of the things that you really bring in, and people actually are looking for it, is the diversity of your experiences. And how can you apply, your experience from one field or one discipline into another. And the whole, idea about system sciences and health systems as a complex adaptive system is based on the fact that every specialty, every new challenge in a public health arena affects, impacts, and changes the other specialties as well. So it will never happen again that, one specialty and I can only talk about that. No. And so I think this is exciting. CGEC is holding a conversation about it is exciting.
Thank you. Yeah, and just to reflect on, wholly agree with everything you said, and particularly around the interdisciplinary and multidisciplinary approach. And that one reason I enjoy that kind of work is it opens up so much space for creativity that often isn't there when you're staying very narrowly in your lane. When you're talking about your clinical experience plus public health or plus economics, that's when there's all of this space, especially when you're working with a team of people coming from other sectors. Coming together, you can come up with a really unique, impactful product. Yeah, I think I'm excited by your words as well. Thank you.
Thanks.
Thank you, Amber. Good to see you here. Kelly, I see you off video. Did you want to make a comment?
No, I just really wanted to thanks for joining this. And I guess, my question is, so I'm probably the only non-clinician here. I think I certainly am the only non-clinician here. And my friends and colleagues who have tried to balance, clinical medicine or clinical nursing, midwifery with international health have often struggled, I think, to kind of make that, to bring those two things together, and sometimes feel torn. And I was just curious if you could speak to this group about how have you made that balance work? Do you feel like you have had to prioritize one over the other, or is it a matter of one gets more priority at what time and than the other?
That's a great question. And I think your last phrase definitely applies, that when a certain opportunity arises, then you dial down the other one. But that said, I think especially over the last 5 to 10 years, I've known that my priority was this global health work. So there was less of a struggle when there were more global health opportunities for me to do things, and even things that might have seemed more random opportunities in the global health space, I would have taken over more clinical time. But I would definitely say it has been a struggle, not so much, I think, in terms of the clinical science knowledge, but in terms of just the constant, the administrative and bureaucratic nuances to keep track of. Okay, if it's on Wednesday and if it's a full moon and if it's after 11:15 p.m., don't page this person, call this other person or send a carrier pigeon to the surgeon, right? It's, make sure you manually go into the system and update the timestamp when it's this particular diagnosis. So the things that aren't necessarily related to direct care of the patient and providing them the adequate care, but tracking all of these things that that I would say are system strains or system inefficiencies that often fall on the emergency physician at 1 or 2 in the morning to work around the Epic computer system, or to accommodate the other department, or this one particular person that doesn't want to be paged or messaged but wants a telephone call. All of those things and the constant change of those is more and more is an exponential struggle, when, especially because it's not that interesting, right? And so, but I think to answer your question, I think having one that you're keeping primary helps. I think if you keep both of them primary, that's when you'll run into problems. So for me, it was, I think coming back from Botswana, that was the decision that I had made, that I really wanted to commit to this new line of thinking for as long as opportunities would become available. So that's helped me as my decision making matrix.
No, I agree. I mean, I think the truth is you just can't have it all, right? You can't be all things to all people. And so one has to be primary. I would say, like, there is a tipping point where many of us will stop doing clinical, right? Because the burden of that extra night shift on top of a full plate, as Kelly knows, I'm like quite struggling with my clinical load. It's so hard.
Toddlers, yeah.
And toddlers, children, toddlers, and But I think, like, right now, especially early on in your career, like, the inspiration, the motivation, the ideas, and the relevance comes from the practical practice clinical medicine. And so, like, I've committed to another 10 years. I don't think I can continue past that. And Amit, I wonder if you're in the same boat.
Yeah, I think I'm definitely coming to the edge of my time to do clinical. And I think I had already started tapering significantly several years ago, again, to make space and to chase and to take advantage of these global health opportunities. So yeah, definitely agree with that. But I also agree with your other point, is that particularly to get those early opportunities, part of the reason I got them was because I had that up-to-date, up-to-the-minute clinical experience. And that really actually gave me a ton of authority to speak in rooms of very senior people last year, where I could say, actually, I was treating patients last weekend, and that what you just said didn't make sense, or that is a ridiculous idea. I wouldn't phrase it like that, but I having that experience and being upfront about it, not in an arrogant way, but in a matter-of-fact way, to prevent us from going down a rabbit hole or wasting a lot of time and energy, was pretty helpful for me, I think.
I just want to say thank you so much. Who'd have thought 10 years ago we were in India together at a conference thinking, how do we work here? And now we're right back there. So very much appreciate your continued engagement with the center.
Thank you for the invitation.
All right, thank you, everybody, and we'll close there. Dr. Chandra, thanks for your time. It's been a real pleasure. To the residents and fellows, I can say from personal experience, Dr. Chandra is a consummate mentor. So please, Amit, if that's okay with you, please feel free to reach out to him if you need some career guidance. Thank you, everybody, and have a great week.